those secretions for them to pop up, and same true for pneumocystis. Those patients when they have dry cough, they are not coughing up anything. Okay? So mostly in bacterial pneumonias, the patient will give you a history of coughing up something, yellow, green, rusty, all different colors. So when you're looking at, I know you look at what your physician tells you, this, I'm giving you this patient for pneumonia. But when you're admitting a patient, you want to look at the chest x-ray, pull the film and not just look at the report, what the radiologist has read, and try to figure out where exactly the pneumonia is. Did the radiologist miss something? Which is not uncommon. Sometimes things get missed, and you want to make sure, because if you're going to keep ordering x-rays day after day after day and not follow up on them for improvement, then it doesn't make sense to order x-rays day after day after day, okay? So when you're looking at the chest x-ray, you want to know where the different lobes are. So right side, there are 3 lobes, right upper lobe, right middle lobe, and right lower lobe. And the lobes are important to know when you're looking at the chest x-ray for aspiration, okay? Left upper lobe, lower lobe, and then there is a little lingula there. So when a patient aspirates, which lobe does the aspirate go? Right lobe. If the patient is standing and aspirates, where does it go?
Right lobe.
And if a patient is supine and aspirates, where does it go? So apical segment of the right middle lobe. Okay, not right upper lobe. So you want to know your lobes, looking at the chest x-ray, where they are, and whether you, when you say it's an aspiration pneumonia, does it correlate with aspiration or not? If it's whether the patient was supine or how he was, what was the positioning, that will help you decide whether it truly correlates with aspiration or not. So when you're thinking about pneumonia, the bacteria has to get inside somehow to cause problems, right? So what are the different routes the bacteria can get in? Lung, the function is breathing. We breathe air. We can breathe microbes with the air in the form of aerosols. So when we inhale infected microbial aerosols or microbes, that's how we get pneumonia. Or in patients who are alcoholic or maybe sedated, delirious, seizure patients. Those are the patients at risk for aspiration, and they are aspirating what's there in their own mouth, right? They're aspirating their oral microbes, and that might cause problems. And then the last category is hematogenous spread. So a patient gets bacteremic and gets seeding of bacteria in there, and the classic example would be septic emboli, okay? That sets up pneumonia in the bacteria comes from the bloodstream and sets up pneumonia in the lung. So who's going to give me classification of pneumonia? So Nali. You're going to be picked on. You're going to be the ID fellow.
I don't know how you wanted me to.
Whichever way you would like.
Did you want to do community-acquired pneumonia versus healthcare-associated pneumonia versus ventilator-associated pneumonia, hospital-acquired pneumonia?
Sounds good. So that's what we're looking at. So the pneumonias are classified into the ones that you said hospital-acquired, ventilator-associated, and healthcare-associated. They are all grouped into nosocomial pneumonias because of the risk factors involved. And the third category is aspiration pneumonia by itself, okay? But sometimes it's hard to differentiate between CAP, HCAP. Sometimes there is confusion. There are guidelines, and sometimes those guidelines get mixed up when you try to fit the definitions in our pneumonia definition. So but at least you need to have a background about what each means and what are the risk factors associated with each of those pneumonias. So community-acquired pneumonia, nosocomial pneumonia, which is further classified into hospital-acquired pneumonia, ventilator-associated pneumonia, and HCAP. The nosocomial pneumonia can be further divided based on how many days a patient is in the hospital. 5 days versus more than 5 days. And that you need to know based on what you're going to do with the antibiotics, what antibiotics you're going to use, what is the patient at risk for after 5 days, okay? So you can classify a hospital-acquired pneumonia further into early onset and late onset, and if you want to use a broad spectrum antibiotic, you can justify it based on how long the patient has been in the hospital. Aspiration pneumonia, there's nothing much to explain about that. So community-acquired pneumonia, this is the definition of community-acquired pneumonia. As the name suggests, you acquire it in the community, but the cutoff time period that you have to remember is pneumonia that is acquired outside of the hospital, and it is diagnosed less than 48 hours after being in the hospital. If a patient is diagnosed with pneumonia after 48 hours, it's hospital-acquired pneumonia, okay? So if it's less than 48 hours, and also the patient shouldn't be residing in a long-term, if a patient came from Health South, then it's not a community-acquired pneumonia, okay? So they shouldn't have resided in a long-term care facility in the 14 days previous before coming to the hospital, okay? So that is your definition for community-acquired pneumonia. For ventilator-associated pneumonia, remember that 48-hour rule. 48 hours after endotracheal intubation is ventilator-associated pneumonia, okay? You intubated a patient, next day you see a pneumonia on the chest x-ray. That is not ventilator-associated pneumonia, okay? It could be aspiration pneumonia, it could be hospital-acquired pneumonia, but it is not ventilator-associated pneumonia. Hospital-acquired pneumonia is pneumonia occurring in the hospital more than or equal to 48 hours after being in the hospital and not incubating at the time of the admission. So suppose the chest x-ray at admission was showing some infiltrates, but it was not read as pneumonia, but it was there and somebody missed it. So you can't call it hospital-acquired pneumonia. It's still community-acquired that was not diagnosed early enough, okay? So it's important when you admit a patient in the ER, look at the chest x-ray, because if you miss it that time and see it after 2 days, you don't know what changed occurred, right? So it's important that you personally look at the film yourself. Now
The financial,
Will the chest x-ray lag behind? Will it the person
in,
have
in
it?
some pneumonias, and if the patient is dehydrated, okay? If a patient is dehydrated, sometimes you don't see the infiltrates well. As soon as, especially in the patients with septic and stuff and acute renal failure, and you hydrate them, and you order a chest x-ray maybe 5 hours later, you may see the pneumonia.
So should we order it?
It depends what you find on your exam.
Yeah,
If there's a suspicion of that, or there's a history that the patient provides that, you know, they have been having problems with shortness of breath, coughing up, but just at that time the chest x-ray looks perfectly normal, then you can hydrate them with the chest x-ray.
so in addition to the all-important which antibiotics you're gonna get to,
Yes.
what is the financial reason for knowing the difference between hospital-acquired and community-acquired?
There's no, as such, financial, well, the
Yes.
financial reason is from infection control standpoint, because when you get something in the hospital is getting dinged for, and now everything is getting reported on to the public about what is the rate of every infection in the hospital, so UTIs, what is the rate of surgical infections, what is the rate of pneumonias, hospital-acquired, ventilator-associated. So the Medicare will decide how much money to give to the hospital. If the hospital is performing poorly, if a lot of patients are getting hospital-acquired infections, then it will look bad, that we are not taking care, we are giving something to the patient that we should be taking care of. So the hospital is going to get dinged about it, okay?
And these
There are
report
number
cards,
cut off, like more than this
Yeah, they
many.
won't pay the hospital.
so it's a little bit like readmission,
Yeah.
they're gonna stop paying for certain.
Yeah.
So what
So-
afterward number for how many HCAPs?
Nobody
for
knows yet.
pneumonia?
Well, there's some average that they set with whatever, I don't know how they set up that number. If the hospital is performing poorly, if they're not meeting that percent of whatever the national average is, then they cut off the money. Or the stay that the patient had, they don't give them money to the hospital. So that's the risk, but we shouldn't be, the bottom line is we shouldn't be giving infections to the patient. That doesn't look good. Okay. That's the bottom line. So the healthcare-associated pneumonia, and there's a lot of confusion because many of you asked Dr. Samant, should I call it healthcare-associated pneumonia or should I call it hospital-acquired pneumonia? So you have to know what are the risk factors for healthcare-associated pneumonia, okay? Because it's risk factor-based. So pneumonia in a patient with any of the 6 risk factors, which many of our patients, most of our patients on GMS lists have hospitalization for more than 2 days within previous 90-day period of current admission, okay? Many of our patients are frequent flyer, patients who live in nursing home, long-term care facility, health south, rehab-like places for a long time. If they get any antibiotic therapy or prolonged infusions or wound care within 30 days prior to the current admission, or they get dialysis at a hospital or a clinic, or if they have a family member who has a multi-drug resistant organism. So these are the 6 risk factors. They call it healthcare associated. And the main reason to differentiate all this is there are risk factors for resistant bugs. That's what you're looking for. So when you choose your antibiotics for that patient, if they have any of the risk factors, you would use a little bit broader therapy for them, okay? So that's the bottom line. It doesn't make difference what you call it. If you're not sure, you can call it nosocomial pneumonia and not differentiate it. But if they have risk factors, then you have to, in your antibiotics, worry about them, okay? So that was, the previous one was the risk factors only for healthcare-associated pneumonia. These are the risk factors for nosocomial pneumonia as such. What are the things that make them, more something that you need to cover broadly? So most of the things you saw under the HCAP. The other thing is that there's a high frequency of antibiotic resistance to a certain bacteria in that community. So like in Wake Forest, the levaquin was never used because all bacteria there are resistant to levaquin as such, because there was misuse in that hospital. So levaquin is not there in that hospital. Nobody uses levaquin there. They use moxifloxacin there because the bacteria have not been exposed to it. We don't use moxifloxacin here because it's much more expensive than the other quinolones. Fortunately, we don't have too high of a risk of levaquin here in this community, but if we continue to misuse it, then we will eventually get into that arena, which we don't want to get. Most of the risk factors are similar to HCAP. The only extra one is probably the immunosuppressive disease or therapy, which, it's common sense because they get exposed there again and again in the hospital. They're on multiple immunosuppressant drugs. They get neutropenic, end up in the hospital, get exposed to a lot of different bugs, and are colonized with a lot of resistant bugs. So you want to cover them broadly. So what happens when you have a patient who's intubated? You have this tube, so you have tubes going out everywhere. So you have this endotracheal tube. There's this little cuff. When you suction, you're suctioning through this part, whatever is below this. But over time, there's oral secretions collecting on top of that little cuff, okay? When you use antibiotics empirically, and when you continue them for 10, 15, 20, 30 days, those organisms are getting exposed to all the antibiotics that you are using empirically, okay? And eventually they figure out how to become resistant to those antibiotics, okay? Same is true eventually within a few days. This is a biofilm of what happens in the ET tube within a few days of intubating a patient. It's a biofilm that is all slime, like if you don't clean your sink, all that black stuff that grows over there, that's what's going inside your ET tube. When there is slime layer, bacteria hide in there, and antibiotics cannot penetrate it well, okay, inside that slime. So they are protected from host defense. Most of us get exposed to a lot of microbes. We are working in a high-risk environment. All of us don't get pneumonias because our body fights it. We have host defense. We are not immunosuppressed. We are immunocompetent. Our body fights it. But when we put artificial devices like this and biofilm forms and bacteria hiding there, with whatever we do, the bacteria are still hiding. The antibiotics are not reaching there. So if by chance those microbes get loose or the cuff gets deflated or misplaced and the patient aspirates, all those resistant bugs are going in their lungs, okay? The other thing is we keep doing sputum cultures or endotracheal cultures when a patient spikes fever or white count goes up. They're not having fever, white count goes up. They get pen culture, urine culture, blood culture, endotracheal tube culture. And you keep growing that same multi-drug resistant pseudomonas again and again and again, but the chest x-ray is clear, but the patient is on antibiotics. So what are we treating? Okay. So ask yourself the question next time when the chest x-ray is clear, sputum is growing a monster. Do we really need to treat a colonizing monster, which is not really causing a problem in a patient's lung? Okay? So look at what is going on with the patient. Don't treat the culture, treat the patient. Okay? See what's going on with the patient. Because it's not unusual for them to have colonizing bacteria in the EP tube. This is what I just spoke about. So what are the common agents for community-acquired pneumonia? So amongst bacteria, staph and strep, okay, those are the common. Community-acquired pneumonia, gram-positives are more common, okay? When you go to the nosocomial pneumonia, you get more gram-negatives on the top. Staph aureus is still there in nosocomial pneumonia at the top, but it's more gram-negatives for nosocomial pneumonia. For community-acquired, it's still gram-positive. The funguses, the one that we see in Alabama more commonly, and mostly you see in HIV patients, but you could see it in other immunosuppressed patients. We don't have a whole lot of bone marrow transplant population or other immunosuppressed that we see too many opportunistic infections. But histoplasma is the most common one that we see in this hospital. And you may see some aspergillus, but histoplasma is the most common one that we see here. Among viruses, the most common, the season is coming, is influenza, okay? That's the one that we most commonly see. Adenovirus and the other viruses can cause problems, but the most common still is influenza. Among the atypical agents, mycoplasma, chlamydia, legionella, are the common things, and other among HIV patients, the most common thing you see is PJP, okay, pneumocystis. I want to talk about aspiration because if I run with you on the weekend, you're going to get this question, so you better get it right next time around with you. When a patient aspirates, there are three things possible. Patient can get chemical pneumonitis, which is acute onset, because oral secretions and the oral fluid is not good for your lungs. It's not the normal part, okay? So it just irritates and causes pneumonitis. So patient may have fever with that chemical pneumonitis, okay? Bronchial obstruction, if they aspirate whatever food they are eating, okay? Then, you know, and one time I think when I was a resident, there was somebody who ate up the fentanyl patch to increase the effectiveness of fentanyl patch, and it got stuck down there, so they had to do emergency bronchoscopy and get it out.
Sounds like you're trying to snort it, actually.
But people do all kinds of stuff, so bronchial obstruction, but that's also acute onset. The patient will be acutely symptomatic. The third is the bronchial aspiration pneumonia. It is not acute onset, it is insidious. So days after aspiration, the patient will start having problems. Patient will start complaining of shortness of breath or coughing up phlegm, and most of the time with aspiration it is foul-smelling sputum, okay? Because what is foul-smelling that they aspirate that gives bad odor? Anaerobes, right? So that is what smells bad, okay? So aspiration pneumonia, what are you going to look? What antibiotics to use is the teeth, okay? If a patient doesn't have teeth, they do not have anaerobes in the mouth. So if you call it aspiration pneumonia, and if I ask you on the weekend, did you look in the patient's mouth? That's what I'm asking. No teeth, no anaerobes. No anaerobic coverage needed, okay? So you don't need to cover them. So next time, look in patient's mouth before you initiate anaerobic coverage for an aspiration pneumonia, okay? All right. Who do I pick on? Juanesta.
25-year-old male cigarette smoker with fever, called rusty sputum times with weak sputum gram stain shown. Diagnosis, C. Gram positive.